Hi, my name is Kristen Clem, and I'm presenting the case connections for Unit 4. Beginning with case number 1. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The first question states, which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? There are 4 options. A. Blood glucose. B. Urinary acids. C. Serum fatty acids. And D. Plasma glutamine. I chose option D. Plasma glutamine. Glutamine is a non-toxic and non-essential amino acid which takes part in the detoxification and transport of ammonia. In the urea cycle disorder, along with the rise of free ammonia, plasma glutamine levels are also elevated. On the contrary, glutamine levels are normal in beta oxidation defects. A full blood workup was ordered for this female, and the data is presented. The initial blood ammonia level was elevated at 314 micrograms per deciliter, and normal is anywhere from 17 to 80, and it rapidly rose to 600 micrograms per deciliter. The urine orotic acid level was markedly elevated at 473 creatinine, and the plasma citrulline level was normal at 10. The next question is, in this patient where orotic acid levels are elevated, please list the urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. Looking at the lab reports and viewing the patient's symptoms, hyperammonemia, lethargy, and apnea, which are the patient's symptoms, this most likely is the ornithine transcarbamylase deficiency, otherwise known as the OTC deficiency. Deficiency of the OTC leads to increased carbamyl phosphate, which diffuses in the cytosol and then converted to orotic acid. The next part, the enzyme that's least likely to be impaired will be carbamyl phosphatase synthase 1, otherwise known as CPS1. CPS1 is least likely to be affected since it appears upstream of the carbamyl phosphate in the urea cycle pathway. It catalyzes the formation of carbamyl phosphate from ammonium and bicarbonate, and this is what causes the hyperammonemia. That completes case number 2. Moving on to case number 3. A 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and a urinalysis is performed. The results from this individual are such. Just to begin, the normal plasma urate level is less than 7, and the normal urinary uric acid level is 413 plus or minus 78. For the patient, we have a plasma urate level of 10.5 and a urinary uric acid level at 215. The question states, what is the best explanation for the presentation of gout in this individual, and please explain why the other choices are not consistent with the data, and what additional information you may need to decide the root cause. There are 3 options. 1. Overproduction of purines. 2. Decreased salvage of purines. And 3. Decreased urinary excretion of uric acid. Beginning with option 1, the overproduction of purines. Gout occurs when the purine's final metabolite, uric acid, crystallizes and then forms deposits in the joints and tendons. In this patient, more information would be needed to decide the root cause if there was an overproduction of purines, which most likely is not the cause of this patient's gout, because if there was an overproduction of purines, there will also be an increase in breakdown of the purines that leads to an increase in uric acid. Option 2, I believe, is the most correct answer. Decreased salvage of purines. Because hypoxanthine and guanine arise from the breakdown of nucleic acid, and the absence of hypoxanthine guanine phosphoribose transferase, which is also known as PRPP, the level rise and the purines are overproduced by the de novo pathway, resulting in high level of uric acid production and gout-like damage to the tissue. Option 3 is the decreased urinary excretion of uric acid. Gout is a form of arthritis caused by excess uric acid in the bloodstream. The symptoms of gout are due to the formation of uric acid crystals in the joints and the body's response to them. Decreased urinary excretion of uric acid is very common, but with our patient's lab information, this does not seem to be consistent with the explanation of the root cause of gout. Further on, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar in diet soda was bad for him. He tells you he drinks before 4 and 5 liters of soda a day. Note that the primary sugar in most sodas is fructose or high fructose corn syrup. The final question states, what is the potential impact of this dietary modification on the presentation of gout? Due to dietary modification, the patient will have a slight decrease in uric acid level, as earlier he was drinking artificial sugar in the drinks, which is much more harmful than natural sugar, as artificial sugar produces more uric acid than natural sugar. And that completes case number 3.